All right, welcome everyone to Organizational Health, Growing Sustainable Culture for Behavioral Health Treatment Providers. My name is Jonathan DiCarlo and I'm CEO for C4 Consulting. C4 Consulting is a subsidiary of C4 Recovery Foundation Incorporated, and we're glad that you took the time to join us and appreciate your investment in our webinar. C4 Consulting is a group of consultants with over a century of experience in behavioral health, providing services to a range of solution-oriented consumers in behavioral health, from startup to current operations and legacy partners. We provide our services in a team approach, and integrity as our highest core value. We look forward to being of service and sharing all of our opportunity for support with you, especially today's webinar. So I'll invite everyone to take a moment and to just take a moment to breathe, as is a practice in many behavioral health care settings, starting with resourcing, starting with the opportunity just to take a moment to breathe and get grounded can often be incredibly powerful and impactful. So I'll invite everyone in their own form or fashion to do so. And with an uncomfortable moment of silence past us, today's webinar goals are the following. First, to examine historical influences of organizational health in behavioral health, to define organizational health and offer some insight into the challenge of those definitions, to look at common challenges experienced in organizational health by providers, to look at common industry responses, patterns, and perspectives to organizational health challenges, and to look at solution-oriented approaches to growing sustainable organizational health. To begin, we'll look at defining organizational health. So what is the organization? In behavioral health, it's often a challenging question to answer. Is it the people, meaning the providers, the employees? Is it the payers, the vendors and partners who support the services that we all participate in? Is it the consumers, the clients, the patients, the participants in our care? And is it the communities in which our organizations reside? Is it just the brand? And I put up a particular slogan that should ring true and hopefully everyone recognizes from Nike. Is it the product and the services? Is it really the organization just what we produce for whom we produce it? Or does it include systems and processes in the way that we provide our organization and the way that we provide our service? What is health? Is it an outcome? Is it performance? Is it a process? Is it a quality? Can it be quantitatively measured? And what does that look like and mean in terms of an organization and its operation? Specific to behavioral health, it becomes a really challenging prospect. So to put some context to it, I'd like to spend a few minutes looking at the historical influences and perspectives. Beginning with looking at industrial and organizational psychology, beginning in the late 1890s and turn into the 1900s, psychology applied to advertising, business models, employee selection, vocational counseling. We really see the advent of what becomes the foundation of organizational and industrial psychology as early as over 120 years ago. We move on and see that industrial psychology gets formalized. And one of the seminal works, Psychology and Industrial Efficiency by Hugo Münsterberg, is published in 1913, and really starts to look at how avenues of people's influence in their thoughts, perspectives, values, and behaviors affect industry and production. We move on and we look at, as things progress in the Hawthorne studies done at Western Electric in 1924, the study of the relationship between illumination and productivity. Being able to look at what has become known as the Hawthorne effect or the observer effect. And as a result of this study, looking at the impact of what happens when employees are being observed and what performance changes occur as a result of that. We look forward and say that there's continued exploration of applying psychology to business and industry. Advertising and looking at the psychology of advertising becomes a prominent focus for industrial and organizational psychology as it evolves. And we see all kinds of influence of psychology in ad campaigns and the understanding of how to meet consumers where they are, how to motivate consumers, as well as how to motivate employees and the workforce. In the 1940s, we see an example of industrial and organizational psychology come through the Office of Strategic Services, which focused on developing a situational stress test to be able to evaluate performance and look to support employees, particularly in the military and particularly as the historical events of World War I and World War II become a focus for looking at the workforce and changes in the workforce. In the 1950s, we see examples such as the Management Progress Study of AT&T, which incorporated the use of assessment centers to examine promotions. So really starting to look at operational aspects of how not just to look at efficiency, but how to look at the human capacity to grow and how to maximize value for everyone involved in an agency. Industrial and organizational psychology continue and are impacted by the Civil Rights Act in 1964 and the Age Discrimination in Employment Act in 1967, and start to look much more deeply at the influences of some of the cultural shifts occurring at the time and how to account for the impact in workforce and work production. In the 1970s, the publication of the first industrial organizational psychology handbooks influenced uniform sets of employment guidelines. And in the 1980s, we see research, study, and publication. For example, Project A, which was used to identify predictors of good soldiers in the military, incorporated into a focus. So we start to see trends and shifts in where industrial and organizational psychology and where organizational health start to become focused on individuals within organizations and their relationship to the services that are produced. In the 1990s, we see things such as the Americans with Disabilities Act, the Civil Rights Act becoming updated, and the Family and Medical Leave Act begin to influence the study and the process of how organizational and industrial psychology are applied. With the advent of the information age, the internet, email, advances in information exchange and sharing, there's rapid growth and rapid production for industrial and organizational psychology to really understand learning. And in the 2000s, industrial organizational psychology really focuses on advances in technology and how they influence learning, in particular outcome tracking, which becomes relevant for our field as we start to look at it. Current focus for industrial and organizational psychology is really looking at how health and wellness and data analytics, such as quantitative and qualitative data, are combined to influence how organizations function, what the definitions of effectiveness are, and what success is for everyone involved in an organization. As we look at the evolutions in organizational and behavioral health, we start back at the same time point and see the early formation of advocacy groups to challenge conditions of care, starting with the Connecticut Society for Mental Hygiene, which today is known as Mental Health America. We start to look at things like the Surgeon General adopting a mental hygiene program for the Army and Navy in preparation for World War I. We move on in the history and see changes to commitment laws as a result of advocacy groups in several states looking at revising commitment laws and policies and practices. So we start to see where industrial and organizational psychology start to influence what become the practices of our field. In the 1930s, continued reformation and advocacy for practitioners really merge, as well as, in particular, for addiction treatment, the foundation and starting of Alcoholics Anonymous, beginning and growing, and the advent of self-help groups influencing this process. In the 1940s, we see the passing of the National Mental Health Act in 1946, and the creation of the National Institute of Mental Health. So we start to see government regulation and interest in the process of examining how to regulate and support behavioral health. In the 1950s, we see things such as the Joint Commission is founded and the first Diagnostic and Statistical Manual of Mental Disorders being published. So we start to see a range of influences looking at what is the definition for services for organizations, how are organizations monitoring their practices, providing consistency, and producing health for their consumers. As we move on in the history, excuse me, in the 1960s, we see active legislation of a variety of things come to pass. Community Mental Health Center Act is published, authorizing grants for community mental health and calls for deinstitutionalization and increased community services. We see the initiation of the laws that founded Medicaid and Medicare. And as well, we see CARF International being formed from the combining of two organizations that previously existed to look at standards of care in human service operations. As well, we see a revision and a new publication of the DSM-2 in the late 60s. In the 1970s, the Alcohol, Drug Abuse, and Mental Health Administration is established and replaces the NIMH. NIDA's Advisory Council is established. We see the Rehabilitation Act being passed, widening the types of concerns for services that are regulated and provided with oversight and support. We see the initial prospect of the Health Maintenance Organization Act, which directly promoted the development of what we now often refer to as HMOs. We see the Council on Accreditation, or COA, being founded in the late 70s, offering another perspective on standards of care. We also see the formation and the beginning of the National Alliance on Mental Illness, or NAMI, in the late 70s. As we move forward into the 80s, we see revisions to the DSM-3, shifting from the former psychodynamic influence to a more medically driven model and being developed with coding and billing practices at the time. We see managed care really come into form and focus with reforms and reimbursement models that were introduced to increase efficiency and productivity for client service and client care. And in the tail end of the 80s, we see revision to the DSM-3 being published as well. We move on and see that SAMHSA was established, renaming the government oversight and agency support opportunities. We see the DSM-4 being published, and we see the initial advent of the Mental Health Parity Act coming into focus and becoming an issue. So we start to see shifts and trends in behavioral health that are really influenced by consumer need, consumer advocacy, service need and service advocacy, and the partnership between organizations providing behavioral health services and agencies designed to help support increased standards and quality of care. In the 2000s, we see the publication of the DSM-4 with its text revision. We see the advocacy of Mental Health Parity and Addiction Equity Act coming form, and really presenting an opportunity to be more inclusive of what is considered covered and allowable for mental health and substance use disorder care by allowing consumers more access to benefits and access to a variety of different services. And in 2010 and going forward, we see that those laws are amended really by Healthcare and Education Reconciliation Act, or Affordable Care Act as it's often referred to. We see revisions to the DSM come out in the DSM-5, and we see that the need for outcome measures and tracking trends begin to rise and are really being formed at this point to inform client care, to look at service delivery, to revise accreditation standards for payer validation, to look at challenges in behavioral healthcare organizations, and to really increase accountability and responsibility for consumers, payers, and stakeholders. So what does all this history tell us? Well, ultimately, one of the things that comes forward is that although both fields have seen advances in shaping interests and growth, the focus for industrial and organizational psychology and behavioral health have focused on management, operations, and culture. So if we look at that starting from the aspect of how employees are viewed, how processes and technology are incorporated, and what defines an organization, we start to learn that none of the challenges that we're facing today are new, and that the historical context can give us a lot of insight into what pathways to success for growing organizational health can become. We look at and say that it's challenging to account for all stakeholders in defining behavioral health organizations. what makes up the organization, how do we account for it, how do we partner with those stakeholders, and how do we process and communicate information for change, growth, and health. We also see that it's necessary to understand the relational context of the resources consumers and providers share to improve, maintain, and grow health, specifically in the areas of healthcare support, funding sources for healthcare, and how operations adapt to the changing conditions with legislation and standards of care, and understanding what the context of those resources are to really maximize the opportunity for people to receive care and for behavioral healthcare organizations to maximize their opportunity to provide the best service possible. And lastly, we see that from the historical perspective that organizational health is a paramount priority for behavioral health providers to ensure the highest quality of care can be produced with consistency and integrity. And those challenges aren't lightly looked upon. So in order to define organizational health, we'll give a couple of examples. So our first example is organizational health being defined as the state of complete and unimpeded operation of all formal and informal, main and auxiliary organizational processes. Sounds like a standard dictionary definition, and when I think about how to incorporate that into a practice, it becomes harder because some of the specifics are absent. So we look forward and take another definition and say, is organizational health defined as an organization's ability to function effectively and to cope adequately to change appropriately and to grow from within? And in this definition, organizational health consists of 10 different dimensions: goal focus, optimal power equalization, cohesiveness, innovativeness, adaptation, communication adequacy, resource utilization, morale, autonomy, and problem-solving agency and adequacy. Looking at that definition, although it provides more specificity, there's a lot of operational challenge to being able to think about how do we apply that to behavioral health. So I offer another example. So this example defines organizational health as essentially about making a company function effectively by building a cohesive leadership team, establishing real clarity among those leaders, communicating that clarity to everyone in the organization, putting in place just enough structure to reinforce that clarity going forward. Simply put, an organization is healthy when it's whole, consistent, and complete when its management, operations, and culture are unified. And this definition comes from the work of Pat Lencioni from his very famous book, The Advantage. To elucidate further, Lencioni says that there are two requirements for success. The first requirement is that an organization needs to be smart, so it needs to have informed strategy, informed marketing, informed finance, and informed application of technology. And it needs to be healthy. And his definition of health includes minimal politics, minimal confusion, high morale, high productivity, and low turnover. And when we combine those two elements, and we start to see where an organization can define itself in a concrete way that's operable, that's relatively simple compared to more complex definitions, and can be tracked through an entire system. In Lencioni's model, to build out the process, building a cohesive leadership team, creating clarity, reinforcing clarity, and over-communicating clarity are necessary and the foundational steps to his model. In order to affect that, he reinforces concepts that he's published in other works around team behaviors. So the essence and the foundation of the need to build trust, mastering conflict within teams, achieving commitment within teams, embracing accountability, and focusing on results. And with all of those combined, we also start to see where some of the challenges that come up for a behavioral health organization when looking at defining organizational health. Lencioni's very famous 5 dysfunctions of a team are set up in this way, where we see at the foundation the dysfunctions of the absence of trust, influencing a fear of conflict, influencing the lack of commitment, influencing an avoidance of accountability, leading to an inattention to results. And the inattention to results is interesting, ultimately in defining organizational health, because what those results are incredibly important. And usually inattention to results takes 2 forms. One is not measuring anything applicable to the organization. And two, it's really measuring the wrong things. So being able to look at how the process of these 5 common dysfunctions operate in a team can lead us to looking at how an operational definition of organizational health can come. So in Lencioni's model, he clarifies and says, to create clarity, we need to look at 6 critical questions. Why do we exist? How do we behave? What do we do? How will we succeed? What is most important right now? And who must do what? And when we think about these 6 critical questions, it really is about every aspect of the organization. So that initial examination of what makes up an organization really is every aspect, really being able to look at fundamentally these 6 critical questions gives a very concrete pathway for someone to define organizational health and for someone to be able to take action on assessing it and growing it in a sustainable way. If we look at the organizational tools at our disposal, in particular in behavioral health, all behavioral health organizations have a mission, a vision, and a set of values. And those values can be defined in several different ways as core values, aspirational values, or permission to play values. We look at the fact that based on our history, that we have policies and procedures and practices. And oftentimes, all 3 of those operational tools offer an inconsistency or a challenge for organizations. We look at strategic goals and tactical plans and the reasons for there being a difference between having a strategic goal and what's a tactical plan and how does that evolve and adapt. We look at accountability and responsibility and look at the tools that behavioral health organizations use to produce accountability and responsibility within their service production and delivery. We look at the aspect and the essentials of communication and the communication tools that organizations use going forward, and we see how quickly that communication becomes challenging as an organization grows. As we typically move forward, we see the importance of verification, meaning meeting the standards that are intended by our organization, and validation, meeting the needs of the recipients, both of the services and for the providers producing those services. I'd like to introduce the concept of looking at organizations and family systems briefly because of the power of it, specifically in behavioral health. Are there similarities between a healthy organization and a healthy family system? When we look at Lencioni's definition of a healthy organization, we see some parallels to common definitions of a healthy family system. We see leadership being cohesive as parents. We see organization and clarity for communication, so time, discipline, attention, affection. We start to see that in a healthy family system as well as a healthy organization that there's a responsibility for everyone involved in the system, both for leadership as parents and for the remaining portions of the agency as participants or members of a family. Are there similarities between an unhealthy organization and an unhealthy family system? And this is often easier to see than trying to define a healthy organization and a healthy family system. So in unhealthy organizations, do we see any commonalities? Do we see unhealthy conflict orientation? Do we see a lack of communication or conflict-oriented communication that results and produces abuse and neglect? Do we see various types of dependencies being a part of an unhealthy organization or an unhealthy family system? And what do we see the impact of the relationship between an unhealthy organization in a community and an unhealthy family system in a community? I'd like to ask the question and say how people recreate their own family system in the organization. And this is not a new perspective and has been well documented throughout organizational psychology as well as behavioral health system practices. But to acknowledge the power of examining this process. To illustrate this, I recently did a training workshop with a treatment organization. And what we did was essentially a classic family sculpture, taking classic family systems theory. And we took each of the teams, the clinical team, the medical team, the administrative team, and had them organize themselves in a classic family system role. defining who in the team were the parents, and using a model to look at roles in a family system of the children, hero, scapegoat, comic clown, lost child, or invisible child, chief enabler, and ask the organization team to identify within their smaller teams what that system was like and who fulfilled what role. Then what we did is ask them to take in their relationships between the teams to be able to say, is that any different on a larger scale within the organization? And what were some of those role changes? And the power of this exercise really gave insight to the organization to say that people always have their own family system roles that do come to work with them, but that may be clearly different in a smaller team in a particular department, as well as shared roles for different parts of leadership in an organization that change when we scale upward to looking at the entire organization as a family system. We asked the question, how does the organization recreate family of origin of issues for its participants? So is the behavioral health system or organization recreating roles that elicit those same responses that are the family of origin issues, and perhaps incidentally or accidentally reinforce unhealthy behaviors without being aware of its own role? So we start to see the need to look at a behavioral health organization from a family system perspective being incredibly valuable. As always in behavioral health, we inquire and say, what parallel processes do we attend to? And so what parallel process from the treatment that we're providing to the consumers and the populations and communities that we're serving do we evidence and do we pay attention to? And how do we pay attention to those parallel processes? How do we track that information? How do we see the benefits or disadvantages? How do we see those parallel processes promoting health and allowing us to be able to produce safety and trust within our organization and for our participants? And how do we look at incorporating and tracking that over time to help influence organizational health? Simultaneously, we look at what parallel processes do we tend to ignore. So are there things going on in our own processes and organization as a family system that we want to shy away from for various reasons? Are they challenging? Do we believe that they're happening? And we'll spend a bit of time looking at that as we look at common challenges that organizations experience. So to reiterate, the definition that I would suggest is simple, concrete, operational, and applicable to behavioral health organizations is Lencioni's definition. So being able to look at organizational health being about a company functioning as effectively as it can, through a cohesive leadership team, establishing real clarity among the leaders, communicating that clarity to everyone within the organization, and putting in place just enough structure to reinforce that clarity going forward. Common challenges that behavioral health organizations specifically experience from our perspective are often misunderstanding the market and trends that are occurring in the service that people are trying to provide from their organization, looking at inconsistency within the organization from two specific vantage points, being able to look at the influence of organizational identity and how that changes over time, how an organization sees itself and wants to be seen by its consumers and the community it resides in and the public at large. We look at a fragmented organization as a common challenge, and we'll look at particular aspects and challenges within what people often refer to as the silo effect, and how a fragmented organization presents specifically for behavioral health challenges to integrating and providing integrity and producing health for its members and for its participants and service communities. And we'll look at how a common challenge is that often behavioral health organizations show signs and symptoms of some of the issues that they're focused on treating and serving. So being able to look at, again, parallel processes and how that's accounted for within the organizational health perspective. So in Misunderstanding the Market, one of the most common things that happen is not really tracking changes to market conditions. So looking at changes in client populations and what people are presenting with as they receive and seek services. Being able to look at examining our perspective on how we assess needs, how we determine needs, and how we meet those needs as conditions change, evolve, and as our diagnostics and understanding of how to provide those services change and evolve. And clearly, based on the number of opportunities that there are, and in a recent anecdotal estimate, there are over 15,000 addiction treatment providing centers in the United States contemporarily. We see that there's no one uniform perspective on how to approach meeting client populations, presentations, and needs, and the need for diversity to be able to meet each individual and system where they are and adapt accordingly. So being able to look at changes in provider populations and stratifications, being able to look at our own industry in and of itself and to see how levels of care and care options have evolved and what are those trends, who is providing service, how are they providing service, and how are different behavioral health organizations partnering in providing that service. We look at payer conditions, regulatory updates, and oversight and demonstrated quality of care standards, and see that that's a moving target that is constantly being challenged and changed. Looking at the opportunity for funding behavioral health service organizations and diversifying security for that organization to move forward, being able to respond to changing conditions. And as we saw in the history of the behavioral health organizational perspective, we saw the onset of challenges and changes to public interest, governmental regulation, accreditation standards, and the need to try and locate more uniform opportunity to understand what are the changing conditions for our sector and our market, and who are we really trying to serve and why. As a result of these, we see organizations often responding with rapidly shifting priorities. So for example, shifts to admission criteria based on census management are an incredibly common example of how misunderstanding the market can often lead to challenges and changing priorities. Shifting admission criteria can compromise integrity of care and integrity of service and ultimately be a disservice to both an organization and a consumer. We see examples leading from that of overreaching to remain competitive, so looking at lengths of stay at various levels of care, and really start to examine how are we serving as an organization our consumer and our community in the best way possible, and how are we partnering with other providers in behavioral health to take away a scarcity mentality that can often drive shifting organizational priorities. With constant shifts to goals and plans, it becomes different for each organization to assess its own health, to maintain its own health, and to remain at a level of operational and service integrity. We look at inconsistency and focus in on a particular aspect. So we say, do the stated goals of the organization match what is produced? Right? So are our mission, vision, and value statements and practices aligned with what we actually deliver? And if there are inconsistencies in those, how are we recognizing them? How are we addressing them? And how are we responding to them? We ask the next question, say, are the stated methods of the organization matching up with how service is delivered? So being able to say that we practice a certain modality in behavioral health or a certain combination of modalities, a certain set of values, and we see how maybe there's not alignment with how service is actually produced. So questions of organizational health really come into focus about being able to say, how do we assess, measure, track, evaluate, and change those kinds of inconsistencies? We look at rapidly changing organizational priorities leading to great confusion and unresolved conflict, which we'll detail again when we look at increasing challenges and the common responses. But ultimately what we see is the results of insecurity, fear, scarcity, lower morale, lower productivity, and higher turnover in our behavioral health organizations as a common challenge. With organizational identity, being able to look at the history of the organization. So taking the example of a seasonal organization or the elder statesman who says, you know, we know what we are doing, so why should we change? We've been doing it this way and it's worked in the past, so why wouldn't it work today? Being able to take a lack of accountability for organizational identity and being able to question and say, are we really accounting for all of our stakeholders in our identity and in our health? We take the example of the young organization or the new kid on the block, which is often formed from people who have departed from seasoned organizations with the idea of bringing about change. And in younger organizations, meaning any organization from, you know, inception and startup all the way up to an organization of 5 to 10 years of operation, we look and say that oftentimes young organizations take a great deal of time to establish an identity. Although they may have a founding mission, vision, and values, we see that evolve as practices for the behavioral health organization continue to evolve, as focus and alignment continue to become clear, and as organizational priorities continue to try and meet the needs of both the agency itself and the participants who are enlisting their services. And we look at the organization in transition. So an organization that's identity is shifting, saying that we used to do X, but now we do Y. We used to be known for providing a certain type of care with a certain quality, and that quality has changed, and being able to look at what are the impacts of organizational identity in that transition. How are those identities communicated, evolved, and practiced, and what's the impact ultimately on the organization itself in being able to produce care? When we look at the results of this, we see added confusion. We see the emergence of politics, oftentimes power struggles, lower morale, lower productivity, and higher turnover. So we start to see patterns of the impacts of these challenges. As we look at the fragmented organization, I referenced earlier the common term, the silo effect, where different departments operate with different sets of values, different missions, and different visions of what the organization is, how service is to be provided, and what that delivery is. The silo effect is often felt in mid to large size organizations and often includes a bureaucratic process that is challenging to be able to redirect. The silo effect really disenfranchises and creates smaller organizations within organizations. And again, the idea of family system and family health become that parallel process in the silo effect. What department or what team is operating with what values? And what mission, what direction, and what procedures? And how is that being managed? How is it being integrated or disintegrated? And how is that being communicated or not communicated? We look at the division of labor, in particular in fragmented organizations, and see that oftentimes it's divided between leadership, middle management, and the actual service teams that are the frontline providers. You know, in different organizations, I've seen up to 10 different departments in an organization of, say, 50 to 60 employees providing service, which means that multiple people are holding multiple roles, adding to confusion and a lack of clarity. The results become a lack of accountability, often rigid perspectives from the silo effect, little to no collaboration, increased politics, lower morale, and lower productivity with higher turnover. In showing signs and symptoms, it's really looking back at the parallel process. Are our organizations evidencing some of the signs and symptoms of the very conditions that we're trying to help individuals treat and develop health from? So are we exhibiting the illnesses that we treat? And the classic example is the addictive organization. Ann Wilson Schaaf and Diane Fassel published a book entitled The Addictive Organization back in the 80s that gives a great perspective of demonstrating how often in addiction treatment care, organizations in behavioral health emulate the actual symptoms of the disease that they're trying to treat. So the organization itself becomes the addict. And the question becomes, how do we apply health to an organization that operates with addictive capacities? We look at organizations and need to understand also, and is very well documented and I think been on The focus for many individual providers and organizations for the last 5 to 10 years in particular is the organization's role with regard to trauma. And in particular, being able to look in and focus in on the aspects of vicarious trauma from being treatment providers and what compassion fatigue produces. And there's been incredible research and productivity, training, time, and energy devoted to examining the impact of vicarious trauma and compassion fatigue on providers and how that impacts the organization as a whole in behavioral health, as well as being able to look at organizational trauma, for example, the death of a founder or a particular staff member, or the impact of sentinel events with clients that impact the organization. Oftentimes, we see as a result the parallel process of organizations showing signs and symptoms of the very issues that their dedicated teams, their dedicated individuals, and dedicated process, all of the knowledge, expertise, intelligence, and passion are aimed at treating, start to evidence those very same things without a lot of recognition or with a real challenge of being able to identify what the role of a particular trauma or the role of trauma is in organizational health. So common organizational responses to these challenges often evidence themselves in denial, which can have various forms, from avoidance to blame, justifying, rationalizing, and even hostility. As identified in some of the results, we noted that confusion, increased politics, no or little collaboration result. So flat out denying that any of these challenges are occurring is often a common response when an organization looks at its own health. We see challenges to when organizations only use internal resources. So someone or a small group in the organization has decided to lead a change in health with limited support or buy-in that's system-wide. So an organization trying to treat itself for its own signs and symptoms, its own illnesses, its own issues around health, and its own challenges, without accounting for being able to have the right resources, the right level of support, and an actual clear way for all stakeholders to participate in the process with mutual responsibility. Oftentimes, organizational responses to challenges evidenced by external forces being brought in, the third party being brought in to make change with limited support for follow-up or follow-through. The example of a consulting organization such as C4 Consulting, or the famous Bobs of the movie Office Space, coming in to make change, but ultimately not being integrated in a way that accesses the organization's true resources. So just relying on an external party to be able to develop health being a common practice. The training trap, right? Addressing the symptom but not the source. And this goes back to, being able to see those parallel processes and looking at what we identify, being able to offer trainings to parts of an organization in whole or in parts, and being able to see that just training is a trap. It doesn't provide an opportunity for true integration if we don't account for how the integration of that training is really conducted, performed, tracked, evaluated, and ultimately made part of the definition of an organization's health. So providing training without consistent follow-up or follow-through, and not being able to be inclusive of staff, so only training parts of the organization rather than a true systemic approach that invites in all different aspects of an organization. And one of the most common examples of that is investing in clinical trainings without including business operations, administrative, leadership, facilities management, and other frontline supports into a training process. So where one area focuses on the service really includes more than just a clinical provider. So solution-oriented approaches to behavioral health really need to include understanding your own organization, to know your own history, to be able to understand what are the things that have been accomplished, how has the organization defined health in the past, has it taken the time, and what were the results? Really understanding the operations ability to look at its people, its products, its services, and its own context, its own narrative and understanding of itself, right? Being able to look at the context of the organization's culture, the role of family systems within that culture, and the process of change for an organization and what's been successful or unsuccessful for that organization. Being able to understand the actual challenges that are identified. So being able to look at the internal dynamics within an organization as a set of providers. So again, emphasizing looking at an aspect of family dynamics and family roles within behavioral health organizations, and external dynamics. Being able to look at resource partners, whether it's within the community that an organization operates in and functions, or in the industry of looking at resources and partnerships that will allow those dynamics to really be accessed and produce flourishing health. We look at understanding what those resources are. So are we really understanding our organization's people, its services, and its systems and processes? And oftentimes in solution-oriented approaches to organizational health, one of those areas is emphasized and the others end up finding less priority, or they're prioritized, but the follow-through doesn't become present in an integrative way. So when we look at solution-oriented approaches, we want to be able to establish baseline health. So the importance of being able to assess the current organizational health. What is the current standing based on a definition that is applicable, consistent, and relevant to your behavioral health organization as a group of providers? Being able to identify, discuss, and solve what some of the issues in creating a definition for organizational health are, and looking at measuring and tracking. So feedback-informed performance, feedback-informed culture, and products and services. And there's a group of treatment providers that I've spent a great deal of time with that's really had great success in incorporating feedback-informed opportunities to be able to have live feedback from the participants receiving their care, informing the practitioners providing their care, allowing management and operations to look at what's actually working in the moment and what isn't working, and being able to see how those changes may need to be addressed and what the priority of those changes are, and providing the support resources to affect that change, ultimately leading to health. So being able to take our own pulse and decide what we need to do. Being able to look at developing an organizational health plan. So what works best for your organization? A particular organization that I'm currently engaged with really appreciates and has integrated the practice of motivational interviewing styles to their operations. So being able to look at things like supervision within not just clinical services, but in business operations, being able to look at their own change process and to know what works best, and to see where lapses in change, stalls in a motivational interviewing process are, to look at how to roll with resistance and how to support change in the healthiest way for each organization. And that difference really becomes unique to the organization and ultimately can be tied back into mission, vision, and values, and specifically in the core values that the organization already evidences and practices. So being able to look at an integrative approach, balancing the internal and external resources that an organization has at its disposal, and not overlooking how things like cross-training, for example, can be employed as a part of an organizational health plan to really increase collaboration, increase communication, increase understanding and compassion. Being able to look within an organizational plan at the differences between the ideas of what are preventative health plan for an organization and what are organizational health maintenance operations, and really being able to distinguish the two. How do we use communication, leadership structure, clarity, and organizational integration as opportunities to identify what we're successful with and what our health is, and where our needs are to grow for an organization to really produce sustainable culture. When we look at solution-oriented suggestions for organizational health, particularly in behavioral health, one of the greatest challenges is being able to engage something that's applicable, relevant, and really develops buy-in for every aspect of an organization. From leadership to management to frontline staff to alumni, to how do community partners get engaged, and really being able to favor simplicity over complexity. oftentimes with approaching organizational health, a lot of complex processes are put in place. They don't become actionable or consistent and end up becoming really a production that adds more chaos and confusion, potentially apathy, or at a minimum, a lack of accountability for all the resources within an organization. So really trying to yield simplicity over complexity. Emphasizing mastering the fundamentals. A colleague of mine often uses a music analogy, being able to say, before you can play jazz, you got to know the standards. So being able to know what are the fundamentals of health for your organization, and being able to essentially wash, rinse, and repeat consistently enough that you're able to then be flexible and have permission to play, to be able to define what those fundamentals are, and to keep them as simple, operational, and tangible as you can within your organization. Part of solution-oriented suggestions that we offer certainly emphasize the power of family systems in the workplace, to really not underemphasize or displace the importance that everyone brings themselves, all of their experiences to them into an organization, and those systems play out regardless of whether people essentially want them to or not. We're often programmed to respond, and we program to respond by seeking safety and comfort, which aren't always the same thing. So what may produce safety for an organization may come from a healthy family system perspective, but what may produce comfort may be unhealthy and also come from a family system perspective. The term that we often use in our consulting work is principled flexibility. And again, yielding to Lencioni's definition of being able to have just enough structure to be able to enact sustainable change. The idea of principled flexibility ties back to having clear mission, vision, and values, to have them clearly communicated, to have them clearly integrated into all aspects of the work that is provided and produced and delivered, and to be able to be flexible about how we apply those principles. Being overly rigid, again, contributing to that fragmented organization and the silo effect. In order to further this, we want to look and suggest one particular area of absolute consistency in behavioral health that can be a grounding force for all organizations looking at trying to define organizational health, to assess their organizational health, and to promote their organizational health. And these really come from the core principles of trauma-informed care. Many of you may have had numerous trainings be incorporating and practicing these principles in your daily work, but oftentimes system-wide in organizations, these aren't accounted for or used as an opportunity to really be able to establish what can organizational health be as a fundamental. So the core principles of trauma-informed care are safety, ensuring physical and emotional safety within organizational health, trustworthiness, so making tasks clear and maintaining appropriate boundaries within an organization, choice, prioritizing consumer choice and control, and in applying this principle in particular to organizational health for behavioral health providers, it really is the consumer not as the service recipient, but within the organization itself, the employee, the staff, as the consumer of the organization's health, and how does it contribute, and what does that reciprocal relationship look like? How is choice embraced, cooperated, and ultimately engaged and integrated in the process of how the organization functions and operates effectively? Being able to look at collaboration, maximizing collaboration opportunities, and sharing power with consumers. And again, consumers being within an organization and those external stakeholders as well. Being able to look at opportunities for empowerment, so prioritizing consumer empowerment and skill building, really looking at the resources that are within an organization, understanding the amount of passion, intelligence, and commitment that exists, and being able to actualize that through empowering opportunities. So rather than having inflexible, often shifting priorities and policies, procedures, and practices, really being able to look at developing empowerment and skill building models within an organization. And lastly, the idea of mutual responsibility, where each person is responsible for their part in the relationship and for their own behavior. So really being able to apply this definition to individuals, to teams, to sectors and operations, to being able to look at the entire organization and how the system ultimately functions.